Okay, so now we're in part 2 of the thyroid series. So we went over last time what the thyroid is, the thyroid hormones, and the autoantibodies that we don't want to see. So we talked about hypothyroidism in the last video, so now we're going to talk about hyperthyroidism. So hyperthyroidism's main cause is what's called Graves' disease. So Graves' disease is once again an autoimmune disorder that is when your body is attacking itself. Last time we had TPO and TGAB that came out and attacked the thyroid. This time we have TSI. So TSI is going to come, TSI is going to bind to the thyroid, mainly the TSH receptors, and it's going to stimulate the release of T4 and T3, that thyroid hormone. So TSI is going to bind to thyroid, and stimulate that release of the hormones. So in this case, it binds to it, and it also causes hyperplasia, which is that sort of distortion of the cells. So in hyperplasia, it keeps happening to the thyroid, and we end up with a goiter because it has grown in size. So you get hyperplasia, and that gives you the goiter. Now, what the hormones are going to look like in someone who has Graves' disease is instead of having a low T4 like last time, they're going to have a high T4 because they're hyper. Now, if they have a high T4, do we think TSH is going to be high as well? No, because it wants the loop to stop. So in this case, TSH is low. So T4 is high because it's hyper, and TSH is low. So that's our basic intro to Graves' disease. So this TSI comes and binds to the thyroid, stimulates that thyroid hormone release, and you get the hyperplasia and the goiter. And it also makes you have too much thyroid hormone, so then you become hyperthyroidic. So in that case, you get all of the signs and symptoms of being hyper. Everything speeds up, you get the tachycardia, you get the diarrhea, you get everything that's much faster. These people also don't like to be hot because their basic metabolic rate is much faster, so they are naturally very warm, so put them in a calm, cool environment, all of that. Again, pay attention to your chronic lecture and that'll help you make sense. So that's our intro. So now we're going to go over some drugs that help people who are having that hyperthyroidism. So there's 3. The first 2 are very similar. They're pretty much the exact same except for their names. And the last one is a very intense treatment that has a lot of nursing management. So you know how it is. I'm going to grab my drug cards. We're going to go over the 2 first that are very similar. They're pretty much exactly the same except for their names. So I will write them as a team. Their class is anti-thyroids. Anti-thyroid. Because that thyroid's too big, too much hormone. No, we don't want that anymore. So we get the drug names of methimazole, and propylthyroxine. Kind of a hard word to say, not super fun. You can just call it PTU if that makes it easier for you. So these drugs are anti-thyroid. They say, no, we have too much of the thyroid hormone, we don't want that anymore. So their mechanism of action is to interfere with hormone synthesis. Synthesis, it's a hard word. So the mechanism of action is to interfere with hormone synthesis. We don't want any more of that T4 created. We don't want to keep getting hyperthyroid. So the indication, if you haven't figured it out, is for hyperthyroid. The mechanism of action is to stop that thyroid synthesis, and our ADRs are, once again, kind of just a list you got to memorize. The first one, we have the rash. You can have a rash, you can have hives, you can have joint pain, you can have GI upset. That's right. You also get a metallic taste in your mouth, which I think is really interesting. So you get like this metallic taste in your mouth, and you also get increased saliva. So metallic taste, and my little up arrow for increased saliva. So those are your ADRs of both methimazole and propylthiouracil, or PTU. Exactly the same, both do the same thing, different drug names. Now, their interactions, there's so many. Our professor just says, look them up if you're going to give them to a patient, because there's many. So now our precautions. Is hepatic dysfunctions. If this person's liver isn't working too well, you don't want to give them a drug that, again, has to be metabolized in the liver, because that's going to be a little bit too much work for their body. So maybe just be a little careful if you're going to give them this drug. Now, our contraindications are nursing mothers. Both of these drugs can cause a little bit of fetal abnormalities, which I will go into in just a minute. And so we do not want to give this to anybody that is nursing a child. We don't want to give this to mothers who are nursing their child, because that could end up with some sort of issue with the baby, and we do not want to do that. So nursing mothers is our contraindication, our absolutely do not gives. So now, one of the differences between methimazole and propylthiouracil is when you can give this to someone who's pregnant. So when you can give this to a pregnant woman, you can only give it at certain times. Methimazole, how I remember what trimesters you can give that in, is I say M for maybe later. So methimazole you can't take in that first trimester. You can take it maybe later, so in the second or the third. Make sense? So propylthiouracil, the P, one of my friends came up with P for pre. So that one you can give in the first trimester. So P for pre, first. M for maybe later, give that one in the second or the third trimester. So those are the antithyroids. The other drug we can give somebody, if we really want to take things up a notch, is iodine 131. Iodine 131 is kind of our extreme measure. This is given to someone if other things are not really cutting it, or also for thyroid cancer. So our indications for this one, right here, is hyperthyroid, or thyroid cancer. Now that's because our mechanism of action for this drug is it is going to destroy the thyroid. It destroys the thyroid via B particles. So it's just like pew, 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 pew. Now I remember that one because the thyroid has gotten so much bigger, or the thyroid is just way too overactive, that we need to stop it. So we're going to destroy it in order to get that job done. So kind of an extreme measure. Iodine 131 is radioactive. That's also something you have to remember. A patient on this needs to be really careful about coming into contact with pregnant women or children for at least a week because they are themselves radioactive. You also do not want to become pregnant within a year because you don't want to cause fetal toxicity. This is a category X to being pregnant, so do not do it, no. All right, so there's a lot of info here. So our MOA is it destroys that thyroid via B particles. So the ADRs, if it's such an intense drug, you can imagine there's going to be a good number of them. So I like to simplify a little bit here. So for my ADRs, a lot of them have an emia or apemia in them. So we have thrombopenia, we have neutropenia, and we have anemia. So they all sound a little bit similar, so those are the three I group together and list first. Thrombopenia, neutropenia, and anemia are those ones with the emia in them. Then we have just a little list of other ones we just have to remember, and that would be a fever, chills, GI upset, headache, because you're taking that sort of toxic drug. Your body's like, why are you doing this to me? So in addition to the emias, we have fever, we have chills, we have that headache, which is HA, and we have nausea. The body's kind of like, why did you do this to me? I'm a little ticked off, blah, blah, blah. So our contraindications, if you can't tell from my emphasis earlier, is pregnancy and breastfeeding. We don't want to give it to anybody who is having any contact with an embryo or a baby because you're just going to be giving that baby a radioactive material and you do not want to cause harm. That's not our thing here. So contraindications is pregnancy, it is category X, or breastfeeding. So don't do it. No. And don't become pregnant for a year after you have taken this drug because you can still be a little bit radioactive for up to a year. It's like 1%, but still, why do it? Our nurse management here, there are many, so I like to simplify it. In the first 8 hours, you want to drink a glass of water every single hour and make sure you go pee immediately. You also, anything that touches your skin, your sweat is going to be radioactive, your urine is going to be radioactive. All of those things that you are touching, you want to wash. You don't want to come into contact with those later because they themselves, due to your secretions, are radioactive. So really just wash everything, just drink that water. For the first week, you kind of want to avoid close physical contact with individuals, sleep alone, don't go up and hug someone who's pregnant. That's not just what we're doing here. We're not coming into contact with anybody that we could harm. Already said, avoid pregnancy for a year. You want to stay 3 feet away from pregnant women or children for that first week. Just kind of give people their space while you kind of work through this. So that's our recap. We had Graves' disease. This is that hyperthyroidism. So you're going to take the anti-thyroids to calm down that excessive thyroid hormone. If that is not working, we're going to give you some radioactive iodine 131, and that's going to destroy your thyroid via those B particles. We do not, that's not our go-to immediately, so keep that in mind. Maybe go with methimazole or propylthiouracil before you jump to the iodine. So there's our understanding of the thyroid. Don't forget to watch the other video if you haven't yet that helps explain how all of these play into thyroid functioning. Have a good day.